Thank you very much, Hugues, for inviting me and put together this very interesting meeting. It's a pleasure to be here today, as always, at the Collège de France. And so today I'm going to use one solid tumor as an example, as a paradigm, if you wish, to illustrate you how differentiation is essential, or the control of differentiation is essential to mediate tumor initiation. And this balance between differentiation and renewal is also fundamental sometime in some therapy that works very nicely in this disease. So as you know, tumor heterogeneity, and today is going to be really a small part of my talk, it describes the difference that exists among a given cancer across different patients. You have another level of heterogeneity that I'm going to also talk a little bit about today. Is intratumor heterogeneity, and that describes more the difference that exists in between the different tumor cells within a given tumors. And some tumor cells proliferate, other cells differentiate, and some cells die, or other are in contact with blood vessels. And so this difference in between the different tumor cells is essential for the metastasis, for the response to therapy, and for many different clinical endpoints. And so the best known mechanism that regulates tumor heterogeneity is the type of oncogenic event, and that's known forever, that different oncogene will lead to different type of tumor. That's extremely well known. Something that was less well known is the idea that the same oncogenic mutation, depending where it targets the cell hierarchy within a tissue, would lead also to different tumors. And so that is called the cell of origin model of tumor heterogeneity. And this is something that we have been studying the last 10 years in my laboratory. We initially start with the skin cancer. Why skin cancer? Because first of all, the skin epidermis is, it's the largest tissue of our body. It's also contains different population of stem cell and progenitor that ensure the homeostasis of very specific compartments. So the hair follicle stem cells only sustain the homeostasis of the hair follicle. The infundibulum, so this part of the skin that mediates the junction between hair follicle and the interfollicular epidermis, the skin barrier, it also has its own pool of progenitor, and the interfollicular epidermis contains a multitude of small units of proliferation containing a stem cell at its center. And so in addition to that, the oncogene that mediates skin cancer were also very well known, and there's two big types of skin cancer, the squamous cell carcinoma and the basal cell carcinoma. And today I'm going to essentially talk about the basal cell carcinoma. And due based on the resemblance of the tumor with the cell type that reside in the tissue, it was hypothesized that the squamous cell carcinoma, because it presents squamous differentiation, would originate from the interfollicular epidermis and the infundibulum, and the basal cell carcinoma, because it presents some resemblance with the hair follicle, was thought to originate from hair follicle lineage. But this is correlation, and correlation sometimes is not necessarily doesn't necessarily tell you the truth. We thought that the ideal way to tackle this question about the cellular origin would be to target different oncogene or different tumor suppressor gene in the different cell type of the skin epidermis, and see simply from which cell type the cancer originates. And the basal cell carcinoma are, this kind of skin lesion that very often arise in sun-exposed region. And when you look at the microscope, so it affects about several million of patients through the year per year. And if you do a section of this tumor, it resembles to a messed up hair follicle. And if you stain that with hair follicle marker, it will stain positive for many of the well-known hair follicle markers. And basal cell carcinoma is due to two types of mutation, either in the patch tumor suppressor gene or in the smooth oncogene. And the person who discovered mutation in the smooth oncogene is Fred de Sauvage, who is sit here in the audience. And either the loss of function of patch or the gain of function of smooth will lead to the constitutive activation of the hedgehog pathway, which lead to the sustained activity of the GD transcription factor, which eventually mediate the oncogenic function. And the most frequently mutated smooth oncogene, the mutation that are the most prevalent is this mutation, which is called SMOOM2. And so using a mouse model that has been developed in the lab of Andy McMahon in Boston, in which the SMOOM2 mutant is fused to the GFP, so you can track in situ where the oncogene is expressed. And in the normal circumstance, this oncogene is not expressed until you remove a stop cassette that prevents its expression using the Crayère system. So by crossing this conditional smooth oncogene with a bunch of different Cree targeting the different cellular compartment of the skin epidermis, we could assess from which cell type this tumor arises. And in sharp contrast to what we were expecting, we found that activating smooth mutation in the hair follicle lineage would never lead to basal cell carcinoma. It can sometimes lead to something that we call dysplasia, and I will show you an example of dysplasia, but never to a frank BCC. And most of the BCC, they originate from the interfollicular epidermis or its junction with the hair follicle. And so then why, it was thought for, decades that the basal cell carcinoma arise from hair follicle is because it expresses hair follicle markers, as I told you. But what we realize is upon oncogene expression, into the adult interfollicular epidermis, these cells change their identity and begin to express hair follicle marker before progressing into an invasive cancer. And so what I show you here is somehow in contrast to what we were expecting, the origin of the basal cell carcinoma is not the hair follicle, and it's coming from the interfollicular epidermis, which are progressively reprogrammed into something that resembles hair follicle. And so using a systematic approach, Khalil, who first discovered its origin, transcriptionally profiled that. And what he found that actually at the early stage of tumor initiation, as you see here, 4 weeks after oncogene expression, it's almost identical to a normal hair follicle, embryonic hair follicle progenitors. And such as LHX2, as you see here in the embryonic hair follicle, is expressed in this early lesion and keep expressing at the leading edge of these tumors. And we show that this embryonic reprogramming is due to a signaling pathway called Wnt beta-catenin, which is well known to be important for embryonic hair follicle development, which begin to be expressed upon oncogene expression. And as you see here, LEF1, which is a transcription factor that relay the Wnt pathway, decorate the leading edge of extremely early lesion in BCC. And when you remove beta-catenin, which is essential for the Wnt pathway, you completely alleviate tumor initiation, completely prevent tumor initiation, and you completely prevent the embryonic reprogramming. So the message here is the change in the identity mediated by hedgehog signaling. It's using a non-mutated activation of the Wnt beta-catenin signaling pathway, which concur to block the normal differentiation, lead to the embryonic reprogramming before progressing into this tumor. But then another question arises. We have shown previously that the interfollicular epidermis is maintained by two types of cells, the stem cell and the progenitor. And there's slow cycling stem cells and rapidly cycling progenitor. And most of the homeostatic, the maintenance of the homeostasis of the skin epidermis is mediated by the rapidly cycling progenitor. And whereas the wounding is ensured more by the long-lived stem cells. And so what Adriana Sanchez in my laboratory has first did is to see whether the progenitor or the stem cell are the cells at the root of basal cell carcinoma. And so we had two CRE, one, the K14 CRE that target both the progenitor and the stem cell, and which lead to tumor initiation. But when we use a promoter that target the progenitor only, these cells, it's not that they were disappearing rapidly out of the game with the oncogene. They can stay here. It's a year after the oncogene expression. These cells express the oncogene. They are still there, but they do not progress into this tumor. And the same was true also for patch. So it's not only a smoothen function, but also it's true also for patch-mediated basal cell carcinoma. And so what we did here with Eduard Hanenzo, very talented theoretical physicist, who was in his postdoc in the laboratory of Ben Simon at the University of Cambridge, we performed a clonal analysis of tumor initiation from the first oncogenic hit until the development of basal cell carcinoma, to try to model, if you wish, the dynamic, the change in the dynamic that you obtain to get a tumor. So this change between differentiation and renewal. And with the progenitor, what we realize is, as I told you, these cells are not insensitive to oncogenic hit. And you see here the clone size rapidly increase following oncogene expression in the progenitor. But they reach a plateau. And this plateau, the tumor cells are frozen into a pre-neoplastic stage called dysplasia. And this plateau is due to a massive apoptosis in the center of this early lesion. Whereas, so despite, the expansion, the imbalance of symmetrical division over symmetrical differentiation, these cannot lead to a net gain of the tumor cells grow after a while. Whereas in the stem cell-derived tumor, there's no this increase in apoptosis, and there's also a huge imbalance between the renewal and the differentiation. So SS means a self-renewing division, PP would mean symmetrical differentiation or symmetrical commitment of the cells. And so there's two reasons to why you need to hit the stem cell. Is first because they sit on the top of the hierarchy, so at each division they generate progenitor which has themselves the capacity of expanding the lesion, and in addition to that they are more resistant to apoptosis. And so we are now trying to understand the reason to why, only what are special in the stem cells that allow them to progress into basal cell carcinoma, and what happened in the progenitor to activate apoptosis here and preclude tumor initiation. So another gene that is very important during basal cell carcinoma initiation, and also illustrates very nicely the importance in the balance between renewal and differentiation during tumor initiation, is SOX9. And SOX9, as you see here, so again, smoothen expression, the oncogene, you see, after 4 weeks, when these cells adopt this round shape, resemble to this embryonic hair follicle progenitor, they begin to express SOX9, and then SOX9 is continuously expressed throughout the tumor initiation. So when we delete SOX9 here, in smoothen-driven tumor or in patch-driven tumor, we completely prevent tumor initiation. But initially, the reprogramming, this embryonic reprogramming also occurred despite the absence of SOX9. But something that was spectacular is the fact that at the beginning, we induce oncogene expression everywhere. After 16 weeks here, you have a massive drop of oncogene-expressing cells. And this massive drop of oncogene-expressing cells, which are, if you wish, outcompete by the non-oncogene, the normal cells, it's totally spectacular, and it's not due to apoptosis. And so then we thought, okay, but why, these oncogene-expressing cells are being outcompeted? And so for that, we perform, microarray analysis and ChIP-seq of SOX9 to see what are the gene regulatory network that SOX9 control to prevent to promote, if you wish, the self-renewing division and prevent the differentiation. And what we realize is SOX9 directly regulates the expression of many different genes that control self-renewing division. HMGA2, which is an important gene that has been shown in the hematopoietic system to be important for self-renewing division. TCF3 and TCF4, which are essential in the gut to promote self-renewing division of the intestinal crypt. And TBX1, which is also an essential transcription factor that are important for maintaining the renewing of the skin epidermis. And upon SOX9 deletion, none of these factors are any longer expressed in the oncogene-expressing cells. Another thing that we realize is SOX9 is binding to the promoter regulatory region and repress the expression of many key genes of the epidermal differentiation complex. So SOX9 is really preventing terminal differentiation. And so when you remove SOX9, somehow the cells that express the oncogene begin to express a lot of the differentiation factor and are lost through differentiation. So what I show you here is SOX9 is a key gene to promote renewal, blocking differentiation, and allow tumor to progress. Now, in the last 5 minutes of my talk, I will explain you the importance of the differentiation in the therapy for basal cell carcinoma. And again, a study that has been conducted by Adriana Sanchez. So, as I told you, in many cases, basal cell carcinoma, it's diagnosed very early during the stage of the disease. You go to your dermatologist, you'll remove that. Some people, in particular in remote area, leave their basal cell carcinoma progress to a stage in which you cannot remove this tumor anymore without removing half of the face of this patient and lose their eye, lose the nose, etc. And so for this reason, the team of Fred de Sauvage at Genentech decided that it was important to develop molecule inhibitor that would inhibit Hedgehog activation, oncogenic Hedgehog activation. And they developed first an extremely potent Hedgehog inhibitor, which is called vismodegib. And upon vismodegib treatment, this tumor beautifully regress, and you see this in this waterfall plot, only very few tumors are resistant from the treatment from the start, but in most of the case, the tumor very nicely regress, allowing the surgery to remove the tumor when they are much smaller, which is very nice. In some case, as you see here, sometimes the response is not complete. And the reason for this incomplete response is not very well known. Another thing is, and that clinician has observed, is upon a very nice response, which you think that you are completely cured, and in most of the case, the patients stop their treatment when they see their face in the mirror and think they are cured. Unfortunately, the tumor can regrow after that. And so this relapse is due to some cells that persist despite the administration of vismodegib for a long time. So we wanted to understand, the molecular basis of this resistance. And we, again, turn back to the mouse model to really understand that, which is a very good model. And so Smoothen-driven tumors are responding very well to vismodegib inhibition. But if you have a little bit an educated eye here, sorry, this is patch lesion, you can see that this lesion is not normal. And indeed, this lesion, they always persist in mice that has been treated with vismodegib. In the smooth-driven tumor, in which we have the YFP fused with the oncogene, it was even more clear. And so sometimes we even see that the tissue was perfectly normal looking. So if I didn't have the YFP here, I would be completely unable to tell you that there's a remaining lesion. But there was. And when you remove vismodegib in this mouse model, what's happening is 4 weeks after, the tumor is back to its size before the treatment. So it's very nicely recapitulating the situation found in human, in which there's some lesion that arise, and this lesion is not, it's not that they had accumulated mutation that render them insensitive to vismodegib, because when you re-administrate vismodegib upon this relapse, again, you are back to the, they shrink and you have a nice response. And if there was a mutation, they would keep growing despite the oncogenic, the administration of the treatment. So, there was 2 questions at this stage. So, first of all, and the mechanism of vismodegib, to how it induced tumor regression was not known. And secondly, what are the mechanisms that mediate the persistence of this lesion and the relapse of the therapy? So when you check for active caspase-3 in tumor that present regression upon vismodegib treatment, there's no significant increase in apoptosis. So it's not an apoptosis mediated. It's not that you kill cells with vismodegib treatment. The cells, if you stain with K67, a marker of cell proliferation, you realize that upon vismodegib treatment, as you see here, all the tumor cells begin to exit the cell cycle and enter a quiescent stage. As I told you, the efficacy of the vismodegib can be seen here by the complete abrogation of GLI1 expression. So we know that we are on target, that we are effective, that we inhibit hedgehog pathway, but nevertheless, there's small cells population that remain here, and they express LGR5, a marker of hair follicle and intestinal stem cells. So we wanted to know, what was at the basis of this resistance. So we genetically profile, transcriptionally profile this resistant lesion. And what we found is, that while I show you, normally there's this profound reprogramming into a hair follicle-like fate, know that when you administrated vismodegib, this reprogramming has been considerably decreased. And at the same time, where you have the decrease in this hair follicular identity, you have an increased expression of interfollicular and infundibulum marker, massive increase of this marker expression. You go from 2% to 20%, very strong increase. And when you check on the tissue, you realize that the tumor cell indeed differentiate into 2 types of fate. The first fate is the sebaceous-like fate, and you see that here with all redo staining or SCD1 staining, in which the cells that disappear, express this marker. A third differentiation pathway that occurs here is the interfollicular epidermis, the suprabasal expression of keratin 10, which begin to be expressed within the tumor upon vismodegib treatment. And so probably, and what we had the chance to put our hands on patient under vismodegib treatment in which we biopsy, and we found exactly the same. This lesion, they enter a quiescent stage and completely abrogate the expression of GLI1, express LGR5, and begin to differentiate into keratin interfollicular-like epidermis with keratin 10, like keratin 1 expression. And so vismodegib is the first FDA-approved drug administered to solid tumors that its main effect is promoting tumor regression through differentiation. Fred will show you, I'm sure, example in non-approved yet drugs in intestinal tumor, and there's more and more, I think, evidence that solid tumor do not escape this beautiful paradigm that has been previously identified for acute promyelocytic acute leukemia and can be very safe and well tolerated for solid tumor. So then how, by learning all this, what can we do to propose to try to eradicate this persistent lesion? And what we realized, this persistent lesion as I told you, they express LGR5. And usually LGR5 is associated with an increase of Wnt signaling. And indeed, when you stain for LEF1, you see that LEF1 was expressed in this persistent lesion, both in the mouse model, but also in the human patient treated with vismodegib. So then we use a combination of drugs associating vismodegib plus a Wnt inhibitor. Here is a porcupine inhibitor developed by Novartis, LGK974. And when you combine the vismodegib plus LGK974, 95% of the persistent lesions are eradicated now, and there's a massive reduction in the tumor burden following the discontinuation of the treatment. So we have long-term eradication of this lesion. So what I show you here is two things. First thing, that vismodegib promote BCC regression through differentiation, that this differentiation left over some cells that are persistent, non-genetically driven persistent lesion that can be at the source of relapse. And if you now combine vismodegib treatment plus a Wnt inhibition, you can completely eradicate that. And so this study was published last year in Nature, back-to-back with a study from Fred's group, who show basically the same overall conclusion of the paper. The only difference that they use at Genentech, they use their own drugs to inhibit Wnt signaling using an LRP inhibitor instead of a porcupine inhibitor. But basically, they also found that you can overcome this persistent lesion by combining these two drugs, which it's potentially a good news for the patient, because this vismodegib is already commercially available, and this Wnt inhibitor, some of them are already in clinical trial. And the good news is for the BCC, you can alleviate the toxicity of the Wnt inhibition by topical administration. Which we show that here. So with that, I thank the people that help us to do the work. So of course I thank the people from my lab, and it was Khalil Kassioussef initially, Jean-Christophe Larsimon and Adriana Sanchez, Ben Simon and Edouard Anenzo for the mathematical modeling of tumor initiation, and Véronique Delmarmol and Joseph Taberneau for providing the precious human sample that help us to do this work. And with that, I thank you for your attention. I'm happy to answer your questions.